Welcome to the Deep Dive. Today, we're tackling a really fundamental question when we look at healthcare. How do we actually know if the care being provided is good? We're going to unpack the crucial topic of measuring healthcare quality and patient safety.
Exactly. And we'll be exploring different ways healthcare quality is assessed and, improved. Think of it as a toolkit of approaches.
Okay.
And we'll be looking at what each tool is designed to do, what it does well, and maybe where it falls a bit short.
Right.
Ultimately, understanding this is key to making sure we all receive better and safer care.
To get a handle on this, we brought together a stack of really interesting sources. We'll be looking at the work of Joint Commission International, a huge influence, right? Global standards.
A very big player, yes.
An article that really digs into how tricky it is to get everyone on the same page when measuring health outcomes globally.
That's a big challenge.
The classic Donabedian model, kind of a foundational way of thinking about quality.
Can't talk quality without Donabedian.
Information from India's National Accreditation Board for Hospitals and Healthcare Providers, NABH, and some different viewpoints on that ongoing discussion. Should we focus more on the processes of care or the actual results for patients? Process versus outcome.
It's a key debate. So our goal in this deep dive is really to give you a clear picture of these different ways of looking at healthcare quality.
Okay.
We want to explore the pluses and minuses of each approach and really understand why this whole area of measurement is so vital for making healthcare safer and more effective.
Okay, let's unpack this maybe by looking at a major player on the world stage. Joint Commission International, or JCI. They've been doing this work for what, over 2 decades now?
They have, yeah. Joint Commission International has really established itself as a leading voice globally. Healthcare quality, patient safety.
Sure.
For more than 20 years, they've been actively working to encourage and support improvements.
And their mission statement is pretty direct: to enable and affirm the highest standards of healthcare quality and patient safety for all. That sounds like, well, aiming high. What kind of impact has this global standardization effort had?
It is aiming high, and their reach is quite extensive. JCI works with over 1,000 accredited and certified programs.
1,000, wow.
Yeah, in more than 70 countries. So this global presence lets them influence how healthcare organizations approach quality on a really large scale.
Okay.
And you can see the tangible impact in, the adoption of best practices and a greater focus on patient safety in many of these places.
So it's more than just giving out seals of approval then. What exactly do they do day to day?
Oh, much more than that. JCI provides a really comprehensive set of resources. Accreditation programs, sure, for different types of organizations,
Right.
but also certifications for specific clinical care programs, and even in newer areas like healthcare sustainability and telehealth.
Telehealth, yeah, that's definitely current.
Right, reflecting how things are changing. They also offer advisory services, guiding organizations, helping them prepare for accreditation, improve quality management, patient safety, infection control.
So hands-on help too.
Exactly.
Yeah.
Medication management. Plus, they have these high reliability tools, publications, lots of educational materials. It's quite broad.
You mentioned telehealth certification. That definitely speaks to the changes we're seeing. I also noticed something called the International Patient Safety Goals. What are those about?
Ah, yes. The IPSGs, they're a core part of JCI's framework. They highlight specific patient safety areas, things identified as high risk globally.
Okay.
So these goals give accredited organizations a kind of roadmap,
Uh-huh.
Focus your improvement efforts on these really critical areas.
And it's not just JCI saying they're making a difference, is it? Our sources included feedback from organizations that have gone through accreditation. What benefits do they talk about?
Yeah, the testimonials are quite compelling, actually. For instance, Hong Kong Adventist hospitals, they emphasized improved teamwork, better coordination between departments.
That makes sense.
Burjil Farha Hospital pointed to increased trust from the community, better risk management, and just a stronger overall culture of patient safety.
Culture change is huge.
It is. Emirates Specialty Hospital highlighted the added value, patients feeling more confident in their care. Corniche Hospital emphasized their commitment to excellence, meeting those high international benchmarks. It really seems the rigor of the process itself pushes these positive changes.
So going through this accreditation isn't just a paper exercise. It sounds like it can really drive meaningful improvements within healthcare organizations.
Absolutely. JCI operates with this clear vision: zero harm, highly reliable care. They even have an upcoming event, Unify 2025, focused on tackling some of healthcare's toughest challenges.
Now let's switch gears a bit and look at a really complex area: The challenge of getting everyone to agree on how to measure health outcomes across the world.
Ah, yes, that is indeed a thorny issue. There's this growing global movement to really understand the value of healthcare.
Right, value for money.
Exactly. Which often boils down to looking at the health outcomes we achieve relative to the cost. And in theory, having globally standardized ways to measure these outcomes, well, it has a lot of potential advantages.
Like, what specifically? Why would this global agreement be such a good thing?
Well, for starters, it would let us directly compare how different hospitals or even whole populations are doing, health outcomes-wise.
Apples to apples comparisons.
Right, and it would significantly simplify comparing results from clinical trials done in different countries. That allows for more robust learning, about which treatments actually work best and makes the global evidence base much stronger.
That makes a lot of sense. But the article we read really emphasizes that we're not there yet, are we?
No, that's a key takeaway. Right now, there's a significant lack of uniformity, a lot of heterogeneity in how outcomes are recorded and measured, even for the same condition.
So it's messy.
Very messy, which makes those direct, meaningful global comparisons really difficult.
And trying to get everyone to agree on these things must be just a massive undertaking.
It is. Reaching consensus on fundamental questions like, which outcomes matter most? How exactly should we measure them? When should we measure them? It's a long, often very challenging process.
Involving lots of different people.
Many different stakeholders, patients, clinicians, researchers, policymakers. And they might all have different priorities, different perspectives.
The article mentioned something called the COMET Initiative. What role do they play in trying to bring some order to this?
The Core Outcome Measures and Effectiveness Trials, COMET. Yeah, they're doing important work. They've created this free online database that catalogs ongoing efforts to develop what are called core outcome sets, or COS.
COS, okay.
These are basically the minimum set of outcomes that should be measured and reported in all clinical trials for a specific condition, using rigorous methods to build agreement. So yeah, they're definitely trying to bring more consistency to clinical research.
So setting a kind of minimum standard for research measurements.
Precisely. And another significant organization mentioned is the International Consortium for Health Outcomes Measurement, or ICCHOM.
ICOM, what's their particular focus?
ICOM places a strong emphasis on incorporating patient-reported outcome measures, PROMs, into their core outcome sets. They call them standard sets.
PROMs, patient-reported. So the patient's perspective.
Exactly.
Yeah.
Capturing the patient's view on their health symptoms, quality of life, satisfaction with care, really focusing on what matters most directly to the person experiencing the condition.
And they made some headway in developing these standard sets, haven't they?
They have. By 2018, ICHOM working groups, and importantly, these include patient representatives alongside clinicians and researchers, had developed standard sets covering a pretty substantial portion, around 54% of the global disease burden.
54%.
Yeah.
That sounds like significant progress. But the article also suggests that getting these standard sets widely used in, actual hospitals and clinics is still a challenge.
That's a really critical point. Despite developing these sets, their widespread adoption isn't common practice yet, and there are several factors contributing to this.
Such as, what are the main obstacles stopping these being used more?
Well, the article points to the difficulty of achieving true consensus within the working groups themselves, sometimes influenced by things like an imbalance in geographic representation, maybe a stronger voice from Europe or North America.
Okay.
There are also inherent trade-offs in selecting specific measurement tools. You have to balance how useful a measure is with how easy and practical it is to actually collect the data.
Right, the real-world logistics.
And then a huge factor is often the cost. Implementing a new or different set of outcome measures within a healthcare system can be expensive.
Cost is always a consideration in healthcare, isn't it?
Absolutely. The article even gives a concrete example from Australia. Researchers estimated implementing the ICO standard set for hip and knee osteoarthritis in just 2 hospitals would cost nearly $66,000 USD over 17 months, just for data collection.
Wow, that really highlights the financial investment needed. And the article also touched on the importance of being transparent about how these outcome sets are developed.
Yes, there's a growing call for more transparency in the protocols used. More detail on who was involved, how consensus was reached, the criteria for including specific outcomes.
And patient involvement, too.
Exactly. Making the level of patient involvement and their backgrounds clearer is seen as important for ensuring these measures are relevant and acceptable.
It makes sense that patients from different backgrounds, different cultures maybe, might prioritize different things for their health.
Totally. The article gives a compelling example. Breast cancer survivors in Malaysia versus those in higher income countries.
Okay.
Overall well-being and survival were important to both, sure. But the Malaysian survivors put a greater emphasis on managing their symptoms, less on social and emotional functioning.
Interesting difference.
It really underscores the need to consider diverse perspectives when defining what good outcomes even look like. What about how feasible these standard sets are in different healthcare systems globally?
That's another really important point. Healthcare systems and the tech available vary enormously, don't they?
Precisely. The article notes that the ICM heart failure standard set, for instance, seemed to align more closely with data typically found in North American or European systems than with data from Africa.
Suggesting a potential bias? Or just difficulty applying it?
Possibly both. Suggesting a potential issue with its development or at least its direct applicability everywhere. Even basic data availability can be a hurdle. Some countries lack the integrated electronic systems needed to track outcomes beyond, say, a single hospital stay.
So a one-size-fits-all approach to outcome measurement might just not be realistic.
It seems very difficult. It sounds like we need to be really thoughtful about how we develop and try to implement these global standards.
That's the core of the challenge.
Yeah.
The article also raises the issue of different outcome sets being developed for the same disease but for different purposes. That could lead to, duplicated effort.
Right, reinventing the wheel.
And then there's a practical reality of what measures are already being used. Switching completely can disrupt tracking trends over time.
Yeah, you lose that historical comparison. Like the example given, maybe switching from the International Prostate Symptom Score, which is widely used, to something newer like EPIC 26, that has implications.
And this isn't just about physical health, is it? The article also touches on the complexities in global mental health measurement.
Yes, the experience with the Onoscale's Health of the Nation outcome scales in the UK shows some of the difficulties. Implementing them, demonstrating effectiveness.
What were the issues?
Well, questions were raised about whether clinician sensitivity or bias might influence how the scales are used. And while ICECOM has developed outcome measures for things like anxiety, depression, addiction, their widespread use is still pretty early days.
So still a ways to go there, too.
Definitely. The article emphasizes needing international collaboration, better training in data collection and analysis, especially in places like Africa, to make mental health outcome measurement truly successful globally.
It sounds like the path to globally standardized outcome measurement is going to be a long and complex one. Lots of different factors need careful consideration.
Indeed. The article wraps up by stressing the need for ongoing collaboration, more transparency in development, considering existing measures carefully, and importantly, sharing lessons learned from implementation in well-resourced countries to help those with fewer resources.
And suggesting practical ways to collect the data, too.
Yes, offering guidance on how to actually gather the necessary information using administrative data, EHRs, registries, things like that.
Okay, let's shift focus now to a really foundational way of thinking about quality in healthcare.
Yeah.
The Donabedian model. I remember learning about this. It breaks quality down to structure, process, and outcome, right?
That's exactly right. Developed by Avedis Donabedian, this model gives us a framework, a way to understand and evaluate healthcare quality by looking at these three connected categories. Think of it as systematically checking all the different elements that contribute to good patient care.
Let's take each one. Structure. What does that actually mean here?
Structure covers all the relatively stable factors, the context where care happens. So physical buildings, facilities, the equipment available.
The tangible stuff.
Yeah, and also the human resources number and qualifications of staff. Even organizational things like how staff are trained, how the system is financed. Basically, it's about the system's capacity to provide quality care.
Okay.
And of the three, structure is often the easiest to observe and measure. You can count beds, check doctor credentials, that kind of thing.
Right, so having the necessary resources and infrastructure. What about process?
Process refers to all the actions taken in delivering healthcare. Everything from the initial diagnosis, the treatments given, preventive care, patient education.
The doing part.
Exactly. And you can break it down further into technical processes, the actual medical procedures and interpersonal processes, how the care feels to the patient, the communication, the interaction.
Okay.
Donabedian himself argued that measuring process was very closely linked to measuring quality itself, because it reflects everything that's actually done during care.
So we're talking about things like, did the doctor follow the guidelines for treating condition X, or how well did the nurse explain things to the patient?
Precisely. And you can gather information about process in different ways, reviewing medical records, interviewing patients and staff, even directly observing care.
And then we have outcome. This is probably what most patients are ultimately concerned about, I imagine.
Absolutely. Outcome refers to the results of the care delivered, the effects on the patient's health or on a population's health.
So did they get better?
Right. Yeah. Changes in health status, behavior, knowledge about their condition, satisfaction with care, overall quality of life, all fall under outcomes. But while improving health is the primary goal and outcomes are super important, it can be tricky to directly link a specific outcome only to the healthcare received.
Because so many other things influence health, right?
Yeah.
Lifestyle, genetics, environment.
Exactly. Establishing that clear cause and effect between a specific process and a specific outcome often requires looking at large groups, accounting for differences, following them over time. Some outcomes don't show up right away.
The Donabedian model sounds like a really flexible way to think about quality, though. I saw it can be applied in lots of different settings.
It is very versatile. You can use it in a small doctor's office to improve patient flow, or in a huge hospital system to assess overall quality. It's also helpful for thinking about managing chronic diseases.
Like the lupus example.
Yes, for something like SLE, analyzing the clinic structure, the CAD processes, and the patient outcomes can help pinpoint where improvements are needed.
But like any model, it's probably not perfect. Are there criticisms of the Donabedian approach?
Yeah, some argue the linear progression, it suggests structure leads to process, leads to outcome, might be too simple. It doesn't fully capture the complex, dynamic interactions between them.
Things aren't always that neat.
Exactly. Others point out it might not adequately consider factors before care delivery, like the patient's starting health or broader environmental factors, which also significantly impact quality and outcomes.
This leads us nicely into that ongoing discussion about process versus outcome measures. We've touched on both through Donabedian, but let's really dig into the arguments for and against each as the main way to assess quality.
It's a really fundamental debate in the field, definitely. Let's start by focusing on process measures again. What exactly are we talking about there?
As I understand it, process measures look at the specific actions providers take or sometimes don't take during care, like using surgical safety checklists or making sure diabetic patients get regular eye exams.
That's a good summary. And advocates for process measures point to several key advantages. First, they often reflect evidence-based best practices. So monitoring and improving adherence means you're encouraging care that's known to be effective.
Makes sense.
Second, process measures are often directly measurable, and the data can be collected relatively easily and often. That makes them useful for ongoing quality improvement work, those PDCA cycles we mentioned.
Right, you get faster feedback.
And finally, some argue focusing on implementing good processes helps build that culture of safety and quality within an organization.
But there must be drawbacks to focusing only on process.
Yes, a main criticism is that it's not always clear if improving a process measure directly translates into meaningfully better patient health outcomes.
Just because you check the box doesn't guarantee.
Exactly. It doesn't guarantee a better outcome for every patient. Also, some process measures can be quite complex to define and implement consistently. And there's the potential for surveillance bias providers changing behavior just because they know they're being watched without real improvement.
So just ticking a box doesn't always mean the patient is better off. Okay.
Exactly. Now let's consider outcome measures. These, as we said, focus on the end result, the actual health status of the patients. Mortality rates, readmission rates, infection rates, things like that.
And the argument for outcome measures seems pretty straightforward. They tell us what ultimately matters to patients, their health. Plus, they often link directly to the financial side, the value equation.
That's right. However, outcome measures also have limitations. A big challenge is attribution. A patient's outcome is often influenced by many factors, not just the specific care at that moment. It's hard to isolate the impact of specific process.
Right, the lifestyle factors again.
And there's a concern that focusing solely on negative outcomes could create a punitive culture for providers. It might even unintentionally encourage avoiding higher risk patients.
Oh, interesting point.
And furthermore, comparing outcome data across different providers or hospitals often needs that complex risk adjustment to account for differences in patient populations.
Risk adjustment, you mentioned that earlier, trying to make fair comparisons when patient groups start out sicker or healthier.
Exactly. It's a statistical method to try and level the playing field, but it's not a perfect science. It can be quite complex. So ultimately, many experts believe the most effective approach involves using a combination of both process and outcome
It's
measures.
finding the right balance.
Yeah. The ideal mix often depends on the specific context, the goals of the measurement, the resources you have, the time frame you're looking at.
The article we looked at focusing on process versus outcome measures in critical care made a really compelling case for why process measures can be particularly valuable there, in the ICU specifically.
Yes, critical care environments present some unique challenges when we think about measuring quality. It's a tough setting.
One of the big ones is just how different the patients are, right? In the ICU, for all sorts of reasons, different levels of illness.
That's a crucial point. Because of this wide variation, this heterogeneity, trying to interpret broad outcome measures like overall ICU mortality can be really difficult.
Why is that?
Well, comparing mortality rates between different ICUs might not be meaningful if they treat very different patient types, or if they're in hospitals with different resources, say a cancer center versus a community hospital.
Ah, I see.
Sophisticated risk adjustment can help, as we said, but it has its limits.
And the article also pointed out that many critical care patients have really complex conditions, multiple organ systems involved, lots of specialists.
Exactly. So a patient's ultimate outcome might be influenced by the quality of care from neurosurgery, neurology, hematology, as well as the critical care team. Makes it hard to attribute an outcome solely to the ICU care.
So how do process measures help overcome some of these hurdles in the IC setting?
The article highlights that process measures often give much more direct and actionable feedback for quality improvement in critical care.
Actionable is key.
Right. If you're monitoring whether evidence-based practices are consistently followed, like using lung protective ventilation for ARDS patients, you can directly adjust areas where compliance is low. Process measures here also tend to need less complex risk adjustment than outcome measures.
That helps.
And the data can often be collected more quickly, allowing for faster feedback loops, quicker implementation of those quality improvement cycles, the PDCA, plan, do, check, act.
PDCA cycles, that's the core of continuous improvement, right? Plan a change, try it, check results, act on what you learned.
Precisely. And with process measures, it's often easier to pinpoint specific actions or maybe omissions that might have contributed to a poor outcome.
Can you give some examples from the ICU?
Sure. The article mentioned using lung protective ventilation for ARDS, like I said, implementing daily awakenings for ventilated patients, starting antibiotics promptly for suspected sepsis, strict hand hygiene, using proper sterile techniques for central line insertions.
These sound like really concrete actions.
They are all well-established best practices. And by focusing on whether they're consistently implemented, you can drive significant improvements in safety and outcomes in the ICU, often more directly than just looking at the overall mortality rate, which is affected by so many things.
Now, just measuring quality, whether it's process or outcome, isn't enough by itself, is it? You need systems to actually use that information to make things better.
You're absolutely right. Measurement is vital, step one. But it has to be embedded within a broader framework that prioritizes process improvement. That's where the idea of a measurement improvement system, an MI system, comes in.
An MI system, okay.
It's not just about collecting data, it's about using that data to drive positive change.
So what does an effective MI system look like in practice?
Well, at the level of an individual patient, an MI system involves measuring relevant outcomes at the start, establishing a baseline, then developing and implementing a care plan. Then, crucially, ongoing monitoring and periodic remeasurement of those outcomes.
And using that to adjust.
Exactly. Use that repeated measurement to inform adjustments to the care plan as needed. It's a continuous cycle of assessment and adaptation for that individual.
The article we read on using outcome measures gave some interesting examples of early MI systems in medical practices. Can you tell us about those?
Yeah, one example was the Dartmouth Coop charts. These were simple visual charts designed to quickly assess a patient's overall health status across 10 key areas of daily functioning.
Visual charts.
Yeah, easy to grasp quickly. The idea was to link these quick assessments with a resource guide for clinicians, offering suggestions on how to adjust treatment based on the patient's reported functional limits.
So, making patient-reported info really practical for doctors, what benefits did they see?
Studies show they were easy for both patients and clinicians to use, and they helped improve communication during appointments, often led to identifying important problems that might have been missed otherwise.
That's valuable.
Yeah, doctors reported that using the cube charts frequently prompted them to consider new treatments or better tailor the existing plan to the patient's specific needs.
And another example mentioned was the Rubinstein functional health status approach. How did that work?
That approach also relied on questionnaires to regularly assess a patient's functional status. The goal was to use this information over time to track progress and guide interventions aimed at improving their ability to perform daily activities.
So these early systems really emphasize understanding the patient's perspective and using that to guide care and track effectiveness. What about MI systems for hospitals?
One example highlighted was the patient judgment system. This involved systematically collecting feedback from patients after discharge using a questionnaire, covered various aspects of their experience and perceived quality.
Okay, post-discharge feedback.
Right. Hospitals then analyzed this data to identify areas where patients felt improvements were needed. These areas were then tackled by dedicated quality improvement teams using structured methods like that FOCCAI cycle again.
So using the patient voice as a key driver for hospital QI initiatives.
Exactly. Some hospitals even integrated the COPE charts into their hospital-wide MI systems, using them to assess patients' functional status after discharge to get a more complete picture of recovery.
The article also outlined some key characteristics of effective MI systems. What makes these systems successful?
Several important elements came up. Strong commitment from leadership is crucial. They have to be serious about using the data for actual improvement.
Top-down support.
Yes. Using outcome measures that are valid and reliable, obviously. Systematic and repeated assessment. Making sure the measurement process is easy to integrate into the daily workflow.
Can't be too burdensome.
No. Easy to administer and interpret. A clear link between measurement results and improvement efforts. The system has to ultimately benefit patients directly, and both patients and clinicians need to perceive it as valuable.
Buy-in from everyone.
Right. And finally, the ability to combine data across patients and compare outcomes with others, that process called benchmarking, is important for broader learning and finding best practices.
Benchmarking, looking at how the best performers do things to learn from them, right?
Precisely. Identifying the most effective processes that lead to the best outcomes. Now, for a larger population of patients, the MI cycle gets more complex. It involves measuring structure, process, and outcomes, analyzing the relationships between them, maybe doing pilot tests of promising approaches.
Field trials.
Yeah, field trials of the best upstream conditions, and then sharing positive results widely to encourage broader adoption.
Finally, we really can't ignore the critical role technology and data infrastructure play in making all this happen. Seems like having the right systems for collecting and analyzing data is essential for effective measurement and improvement.
Absolutely essential. To really understand what's driving outcomes, to identify where improvements are needed, you need detailed, granular data, and you need the ability to track process measures effectively to pinpoint root causes of any problems.
The article from Health Catalyst reminded us of the 3 types of measures again: outcome, balance, and process. And balance measures are there to make sure improvements in one area don't cause problems elsewhere.
Exactly right. A check and balance. And process measures, as we've said, are those evidence-based best practices that help us standardize and systematize improvement efforts.
Like the pressure ulcer example.
Right. Trying to prevent pressure ulcers, implementing and consistently tracking process measures like regular skin checks, following skincare protocols. That's key to reducing bed sores, which is the outcome you want to improve. Process measures help identify where the system might be failing, not just focusing on individual mistakes.
And focusing on process measures can also help ensure more consistent care.
Yes. By measuring processes at various points, you can identify and reduce unwanted variation in care delivery. That leads to more reliable, consistently high-quality care for everyone. Tools like value stream mapping, visually mapping out all the steps, can be really helpful for finding those key measurement points.
But the article also points out that many healthcare organizations struggle. They don't have the infrastructure to track all these different measures effectively. What's the main reason?
Often it just comes down to limitations in their data infrastructure. Traditional ways of collecting and analyzing data can be very manual, very time-consuming, makes it hard to track lots of measures across lots of processes.
So if resources are limited,
they often prioritize tracking outcome measures because those are frequently required for reporting to payers or regulators. Process and balance measures might get less attention.
So the solution is better data systems.
Precisely. The article highlights the need for an enterprise data warehouse, an EDW, basically a central integrated place for all of a health system's data. That automates pulling data together and distributing it for measurement.
Frees up people's time.
Exactly. Frees up analysts to spend less time wrangling data and more time finding trends and insights that drive improvement. They also mention newer platforms like the Health Catalyst Data Operating System, DAIS, as a more advanced system designed specifically for healthcare. Offers more flexibility, more power for analyzing diverse healthcare data, supporting better decisions. Think of it as a more modern way to integrate and analyze all the different kinds of data needed to really understand and improve quality.
Well, this has been a truly deep dive into the fascinating world of healthcare quality measurement. Just to quickly recap some key points. We've explored the vital roles that both process and outcome measures play in how we assess and improve healthcare, along with their own unique strengths and weaknesses. We've also discussed how crucial it is to have robust measurement and improvement systems in place to take that data and actually turn it into real benefits for our patients.
And we've seen the most effective approach often involves a well-thought-out combination of different types of measures, right? Carefully chosen to fit the specific situation, the goals you're trying to achieve.
Yeah.
And while creating standardized measures that work globally is, well, really complex, lots of challenges, organizations like JCI are playing a key role in setting important international benchmarks.
Right.
The Donabedian model gives us that valuable framework for thinking systematically about quality. And ultimately, continuous improvement relies on a fundamental commitment to using data understanding and optimizing the processes of care delivery.
So here's a final thought for you, our listener, to consider. As you think about your own experiences with healthcare, or as you consider the broader healthcare system, try looking at it through the lens of these different quality measures we've discussed. What kind of information do you think would be most valuable in ensuring that you and your loved ones receive the safest, highest quality care possible? And what questions does this raise for you about how healthcare organizations operate and continually strive to make things better? Thanks for joining us for this deep dive.